Okay. All right, Mac, we are here again to open up, and today we are so
Yes,
excited.
we have an exciting guest today. This is new for us. You are our first guest, Dana, by the way.
She is.
So, yes, you're our first guest. This
No
is
pressure, Donna.
very,
No, none. I
but
feel
we're not scared. We're not afraid. We'll just jump right in. We're going to open up. How are you today?
I'm well, thank you. How are you guys doing?
Doing great.
Excited, excited. Let me tell our listeners and our viewers who we are honored to have on our podcast today. Me and Mac, as you guys know, we sit on the board of ICCMO. It's a big nerd fest. It took me a year to remember what the acronym stands for. It's the International College of Craniomandibular Orthopedics. So what we do is a nonprofit group that we take dentists and all different type of specialists to collaborate with one another, learn how to, together take care of patients better and get them feeling better. So one of the people on our board, as we vet speakers, and to our listeners, our speakers don't even get paid to come to our conference. They donate their time because this is what they're passionate about. So again, thank you, Donna. But one of our board members heard you speak and was just blown away. And what she does is that she treats patients with chronic pain condition from a fascial standpoint. And we all get that everything, we're connected head to toe. And just because we're working on the TMJ side of things, you can't treat that without understanding the rest of the body. So, with that being said, Donna, please tell our listeners and our viewers a little bit about you and how you kind of got into this.
So, me in a nutshell, I've been working with chronic pain populations for over 26 years now. While I was getting my degree in college, I got very lucky, had an opportunity, and jumped on it, and have been working in private pay. So that means I've had a minimum of 60 minutes with each person over all of these years. I've been very privileged to do that, which is quite rare when it comes to chronic pain treatment in the normal system. So at about year 13, 14 of practicing, new research emerged, specifically about fascia, which another word for it is connective tissue. Okay. And and I'll explain a little bit more about it, but when that research came through, it was basically giant light bulbs for me as to why some things I've done didn't work and why some things I did actually did. It explained what happened, the kind of the mechanism behind it. And it gave us a complete upgrade to looking at human anatomy and specifically at chronic pain conditions. So at that point, I developed my own method, and now I have OTs and have occupational therapists and physical therapists that are trained in my method that provide the treatments. And we've been really blessed. We actually do this virtually. Okay.
Okay.
Entire, there's no hands-on. And the neat thing about that is that we get to work with people from literally all over the world.
Oh,
And if
incredible.
people speak enough English and have a decent Wi-Fi, they're a potential client. And sometimes we even work with people that have a translator with them. Okay. So that's really neat because you're able to reach more people. Okay. Um, the part that started the virtual originally was before COVID, way before, when people started to fly in to the clinic that we had in Arizona, reaching out to us. I want to fly in. I have chronic pain. I want you to treat me. And I could not ask someone to fly from Singapore on a maybe. So I
Hmm.
developed a method of assessing them virtually first. So the way we still operate is we offer a 45-minute free virtual consult. And if you're a candidate for treatment physically, we're able to drop your pain, the normative pattern. If you're a physical candidate, 50+% within that 45-minute consult. And that's how you know this is a viable option, because I don't need to tell you guys also, like, I'm sure you've ended up with people at your door that have tried the proverbial kitchen sink, right? Try to relieve the problem. And the last thing I want to be is one more modality where they're trying 7 sessions, right? On nobody knows if it's going to work. So that assessment is, I love that we have it. Okay.
Mhm.
And if someone's a candidate to work with us, I explain to them, if you decide to tango with us, what that looks like. And if not, I make sure they walk out of that consult better than walking in. I make sure that I give them, based on what I'm seeing, viable avenues of treatments that they could explore that are also fascia related. And one of the main differences is that those modalities are actually with hands-on therapy, because some bodies, this, after you practice three years on people in pain, not one method is going to work. Not one trick is going to work for everyone. And in fact, I also always tell people, if someone says they have the panacea, walk away, holding on tightly to your wallet. So, right?
Can I interrupt you for a second? Because there's two things that I really want to highlight with what you said is one, the amount of time you take, an hour's time is a lot of time. And if you don't have the business model to allocate that time, you don't have that opportunity to assess people correctly or diagnose them correctly. And I love that about you. And I love that how you're brilliant, but you're also very straightforward. Mac and I always talk about, no, but we don't want to waste anybody's time because these chronic pain sufferers are in dark, dark places.
They
And
are.
I don't want to waste their time and their money or promise something that I can't deliver. So spot on. We're all from the same tribe here.
And that was the lovely thing about it, meeting everyone at that conference at ICCMO, which I'm not going to try to say the acronym the first time. You're going to give me a year like you. Was that it was like a room full of, like, I call myself like an anatomy nerd, right? And all I want to do is help people. And it was like a room full of nerds who want to help people. It was glorious. So
So Dan, I'd like to say something about the internet too. Excuse me. And then it's the problems are the same. The solutions are the same all over the world. And Pam and I can sit in an airport, and I'm sure you do too, and say, well, there's one, there's one, there's one, there's one, there's one. And it's all the same. And so if us collaborating here is just fantastic. So please go on.
yeah, so I would love to introduce connective tissue, fascia, a little bit. And to anyone that's watching this on YouTube, I'll be sharing some images. I'll make sure I try to describe to anyone that's just listening to really describe it. However, we're going to make sure that we put a link even in the podcast that is just audio, that you can access some of these images so you can take a look, because huge amount of people are visual learners. So visuals are very powerful, most specifically when we're trying to learn something completely new. Okay. So I'm going to share those images, do my best to describe them, but I'm also going to try not to completely rely on them when I introduce them, so that those who are just listening right now, right, driving in their car, are not being penalized here. Like, keep it safe, right? So I'm just going to pull up one image that I really, really like. So yeah, and I'm also going to give a resource here as I show this image. So this image is from something called Anatomy Trains by Thomas Myers, which is also a book. Okay, and he also has some courses. And his courses are actually designed for practitioners. Okay, for people who are treating people. So this is a nice avenue to start to learn about this. Now, these images here, I have an image in front of me of a human being from the back, their skeleton. And then instead of using the traditional kind of like red color for muscles that we always use in anatomy charts, you see these lines of what can look like muscles if you don't know what we're looking at, but they're blue, which I thought was really brilliant, because he's trying to separate it from the old model where the muscle theory is all about the muscle, where it originates and where it inserts, where it has a beginning, where it has an end. And it's as though my bicep lives in isolation. Okay, let's say as an example, right? There's no such thing. There's no such thing as just a muscle able to do. My bicep could not lift even a feather if it wasn't attached to everything else, including anchored into my pelvis and feet. Okay, by itself, it cannot do this. So these are images from anatomy trains, and you could also just Google anatomy trains and look for these images. It's called the superficial backline. One of my favorite images to show the continuity of literally from the feet to the head, back to the feet, okay? And there was a line that we quoted a lot in, we kept talking about as we were doing the lecture on at ICCMO, of like feet to teeth, okay? And that can sound a little odd, especially if you're not a practitioner like you two, and you know you're suffering from TMD, and I'm going to call it possibly TMJ, because a lot of people just know that as TMJ, right? Like
Yeah.
temporomandibular, but I'm not going to do the entire thing. It's jaw pain and the associated symptoms with it. You think, well, what do you mean I've got jaw pain? The issue is at the jaw. The jaw, on a good day, is a floating structure. I'm saying on a good day because when it locks on you in TMD, it literally is a closed chain and it is no longer floating. So when it is not floating, it's a problem. Another place that you can think of the term of when we lose the float in the system, and I'll explain that a little bit more. If you ever heard of bone on bone, right? Bone on bone knee, bone on bone hip, bone on bone in the jaw.
Right.
That's when you've lost your float. That's when things are not properly kind of hanging and gliding, and now they're completely compressed and grinding. And again, it's no mystery that when it does that, there's the fancy terms for this is like osteoarthritis. It looks like, gravel in the joint, wherever it is, right? And it's completely inflamed because again, try to do that even just with your own hand and rub like that, you're going to produce heat. You're going to produce inflammation. And inflammation is good for the healing process. Chronic inflammation is the problem, right? So connective tissue is literally the organ of form is how I would like people to think of it. So I'm going to share one other image, okay? I want you to think of it as like your birthday suit, okay? So picture you're wearing a fascia onesie, okay? And I literally use that image from the presentation, okay? So I love this image. By the way, I don't know who to credit. I found it online years ago. I freaking love it, but someone really understood connective tissue when they presented this image of this is fascia's your birthday suit, okay? And the thing about connective tissue, the reason it's called the organ of form, if by an act of magic, I could remove every single bone, every single organ, everything, okay, from the human body, but keep the fascia, you'll have this literal bodysuit on right in front of you, okay, where there are specific pockets for everything where you would know, oh, the heart, that's the pocket for the heart. Oh, the jaw, that's the pocket for the jaw. Oh, that's the pocket for your bicep. That's literally everything into these compartments that are all woven together. Okay. So organ and form. Now, to flip that around, if we try to assess the human body without thinking of fascia, if I could look at a human being and through the act of magic, remove all the fascia, all the connective tissue, I'll have a formless pile of goo in the middle of the room.
Okay.
Like
So
everything in a jumbled mess.
what you're saying is the way we should think of fascia is that it is essentially what helps compartmentalize everything in under our skin and keep it in the right place, but also communicate with one another.
Correct.
Okay.
So it's not just that, but correct. There are actually 6 to 10 times more sensory nerves in fascia than in muscle. So I want you to think if you've ever had a really bad kind of muscle soreness after you've worked out at the gym, right? Like the next day you are walking funny and every time you try to get out of the chair, you're like, oh, right? But it goes away very quickly, okay? And it will not have the nature of that debilitating shooting pain that will take your breath away, okay? Where connective tissue is the kind of pain that like doesn't go. It's not a result of just healthy adaptation that you pushed your body working out, then it goes away. It's not transient. It can become chronic. Chronic simply means over time, stretched out. Technically speaking, for instance, for low back pain, you're considered chronic if it doesn't go away after 4 to 5 weeks. So, and the majority of people that I deal with, it's years, it's normally decades without relief, no matter what they're trying. And I am quite sure that you've dealt with that when it comes to TMD. Okay.
Absolutely. And that's anything that I don't know about you at your clinic, but when TMD is typically a chronic condition unless there's some kind of accident or trauma, right?
Thank
And
you.
if it's accident or trauma, it's a bit faster to rehabilitate and correct, right? But a chronic condition, there's certain therapeutic modalities we have to go through, and it takes a bit more time. And then we have to make sure it can stabilize and normalize as much as possible, given the extent of the degradation, right? So when we are treating when I'm treating, like, let's say I have a TMD patient, right? What's your guide me on this because I don't know. What would be the best time, or when should I know to refer them out to you at your clinic for an assessment? What should I be looking for? How should I advise them?
And that was the question I wanted to answer at that conference, right? So it essentially, the way I look at it is always, first of all, the most non-invasive treatments first, which is, you don't need me to say that, right? That's the obvious thing when you're looking for the best of people. So I recommend try literally all of your tools within, right, your toolbox that are the non-invasive tools. See, does it move the needle at all? Like if you can get them a little bit better, if there's no difference, like what's going on, try all of those things. If at that point you reach, and I'll explain one other exception, like a stalemate, like, okay, a little better, but like, no, like nothing that would be the point to try to look at other modalities, possibly mine, possibly Rolfing, possibly structural integration, right? Those kind of things that will help overhaul the whole system so that the work you're doing at the top of the body and the jaw and the head is going to last, have the full effect. It's the rest of their body that's preventing the area at the top from getting full relief. That would be the way I would go about it. I would be very conservative. Use your tools. Here's the exception. That exception applies to me too. Okay. How do I know when to refer? For instance, I do a test, the most non-invasive test that I can do, maybe 1 to 3. If I even get any form of escalation, I refer. I don't mess. Okay. If they stay the same, I keep trying. I'm safe. I'm not right. Do no harm. Okay. If they get a little bit better, I sometimes even tell clients, every client, it takes 10 to 20 sessions to come out of chronic pain, years of chronic pain. But I literally say, look, we made a small difference. It's not big enough for me. I'll give you other options. If you want to test with us, I'm going to ask for a 3-session experiment. And then if those 3 sessions, we can create a trend, and I apologize for the language, but I literally tell them there's not going to be like, woohoo, in 3 sessions. Okay. It's going to be, if we can make life less shitty.
Yeah.
Okay. Like, oh my God, I'm, able to sleep. And people who've dealt with this know what I'm talking about. I've slept 4 hours, not 2. Okay.
Right.
It's huge. If we can create that, then we keep going. So it's very conservative. I would say if you are trying to treat locally and all that's happening is, right, I call them the hand grenade clients, right? It like pull the pin and everything goes, right? Essentially, that's when you go, okay, hold on, pause. Maybe I shouldn't push more, or very, very gently. And then let's look at assessing you, like sending you here and then come back and all that kind of stuff. Okay. So I always tell clients, my boss is your body. And I can explain there's a way we measure the result and the way we track the result. Okay. That is unique to chronic pain because we don't use the pain scale, because pain scale is, to your point, acute. It's appropriate post-accident, post-trauma. When you live with pain all the time, it becomes meaningless to insulting to infer, right? To invoke the pain scale. Okay. So I can explain that piece too, but that's the way I would go about it. Do everything that you've gotten. I will tell you, I learned something from you guys at the conference. So I do a visual structural assessment and I take screenshots. I can show people what I see. Because like you said, when I walk, don't go with me to the grocery store, right? I'm staring at people in the airport. I'm like, oh my God, oh my God, oh my God, right? Okay. So in the Zoom room, what's nice is I can take screenshots because people don't know. They've compensated for so many years. They have no idea that postures are locked in. When you can show them that, it is a huge light bulb. One new trick that I have from anterior view standing and posterior view standing, I take a screenshot, but then I ask them to gently close their teeth. And then I take a screenshot and the deviation into their pattern goes, whoop.
So cool. So true.
Okay.
So cool.
Which in my world, right? Again, which I already believed walking into this, obviously, I do believe the interventions that you are doing are massively important because you're reducing the exaggeration at how many times per day, right? Do we chew and do all these kind of things that they're throwing themselves further into their pattern.
Correct.
Okay. So yes.
So I love what you say. It's the organ of form. Does it have memory?
Okay. So let's use 100%. Okay. So we've all in the past with the muscle theory, and for many years when I did this, we used to call it muscle memory. Okay. Your body remembers to do that. So let me explain that a little bit. Oh, I have an image I could share, but okay. The way I see it, we need to overhaul two main systems when you're dealing with chronic pain. The myofascia, the term myo simply means muscle in Latin, so the muscle and fascia. And I prefer the term myofascia because you can't separate muscle and fascia except with a scalpel, which we're here to try to prevent. Right. So myofascia, that's the hardware. And we'll discuss the memory of that. Okay. And then there's the software. There's the nervous system that has adapted in that position. So I'm going to say something that anyone, if you're more of a patient or a client in my world, go to the mirror and take a look. If you're right in the dental profession, you know exactly what I'm talking about. You will tell them that their head is on sideways and one shoulder is higher. And they're like, what?
Yeah.
And a fancy term for that is motor somatic amnesia, which basically means you have soma is body. Like you got stuck, you've adapted, and this is what your body thinks is straight. So that's, I could have given you $20 to ask me that question. That's a part of why it is harder to come out of this. Because if I could just open up your fascia and go forth, okay? No, we need to train you into new habits so you don't recreate the old pattern. We literally need, so I'm sure you both are familiar with the term neuroplasticity, which is the term for, we now know that the nervous system is plastic, meaning malleable. We're teachable. We're not just like, oh, by the age of 18, this is it. Okay. So if you did get stuck with that, again, neuromyofascial memory here, right? We're going to need to open it up physically so you're not stuck there, and that will give you relief. That's what we test at the consult, okay? And build on top of that. But then we need to train this to live in the new pattern. We've all heard, I don't know if it's a real quote, but I do like it, Einstein's definition of insanity, right?
Yeah.
And in your world, the appliances, to a certain degree, bypass that because you're forcing muscles, right, to orient and work differently, right?
Yes.
My work, right, I need to go, okay, now that you've got that, I need to teach you how to. Fascia is piezoelectric. That connective tissue suit is like bone. It responds and remodels based on mechanical load over time in gravity. And unless we're in outer space, even when we're sleeping, we're in gravity. So
Say
your
that
fascia
again, 'cause that was so good. Repeat yourself. Can you do that?
and there, by the way, so we do have a YouTube channel, Sterling Structural Therapy, and I did a specific talk about the piezoelectric property of fascia because people need to understand what it's going to take from them with our help to get that new life, that pain-free life. Okay? Because no amount of me on the outside is going to be able to change the way you live in gravity. Okay? Right? I can teach you how, but you're going to need to do it. Okay? So for those who don't understand that term, essentially bone, when loaded in gravity, literally produces the osteoblasts, which are the bone building cells, are like, everybody build more. I'm going to use a perfect analogy, which I also, it's more of an anecdote, but it's very important because the human body is so adaptable that what is amazing that when you give it the correct treatment, it'll forgive 20 to 30 to 40 to 50 years of compensation and pain and be like, I'm good with a good amount of work, but it can do that. So does anybody know how they found out about osteoporosis?
I don't.
Okay, I still remember this from college. Okay. The few things. Okay. They sent astronauts into outer space for 2 to 3 weeks, and they came back with massively reduced bone density. That's how they found out about the relationship of gravity and bone. So now when they send people into no gravity, they have to give them certain things to do in order to not literally come back and crumble in gravity. I'm possibly, hyperbolic there a little bit, but quite seriously. So I want you to think, right? They were in outer space. It wasn't years. That's how quickly your body can adapt. It's brilliant. Now, that's bone. It's also muscle. It's also fascia. Yes, sir.
Okay, so based on this memory deal, if you tell a patient to bite down and they have a deficient maxilla. The brain and the muscles and whoever coordinates the memory has the jaw retrude prior to teeth contacting. However,
It's going to do it.
you take that same patient and you use phonetics to watch the jaw movement, there is no retrusion. So the memory of telling a patient to bite down versus asking them to count are two completely
They are.
different
They are.
motions.
Yes. Yes, completely different motions, and one will elicit the pattern and one may not. So we actually do all sorts of these. And again, I always test it with my client first, and I said, look, we're going to do this thing. It's going to look really weird and feel really weird. If it drops your pain, we're keeping it, and I'll explain how it works. If it doesn't, we're going to pretend we never tried this. It works on a good amount of people. Okay. We do tongue exercises. We don't tell them to do the thing, right? We have them change the position of their tongue. It changes the position of their skull. It can help them literally change the position of the tongue, can help someone that can't go up the stairs without shooting pain, go up the stairs without shooting pain.
Yeah.
Okay. Opposed to just go and walk up the stairs. You're going to go right into their pattern. You have to find these other mechanisms to change the situation, essentially. Okay. Absolutely. So yeah, I mean, the human body is designed for efficiencies. This means that posture, walking, chewing are absolutely not conscious processes. Okay. And I think I said this at the presentation. If they had to be consciously learned, even initially, we would still not have figured out fire or the wheel because we'd be way too freaking busy. Okay. Right. So they're meant to, like, we figured out, we keep going. If we have an injury, if we have a scoliosis, we adapt and we just figure it out, even if though it's a survival strategy, but it's a faulty strategy that can lead to chronic issues. Okay. And it just gets installed in that memory. So you're right. You can teach it to do different things if you just ask it to the same area to do something different.
So let me ask you this. When we create these oral appliances, these orthotics, we are taking into consideration where the muscles are comfortable. Like we can measure that through EMGs, right? We are very familiar with the anatomy of the joint because we've taken a 3D image through a CBCT. So we're taking all of this in account and then creating a hard stop into a new physiologic balanced position is going to start creating memory, if you will, to all of our muscles or systems about, hey, this is our new position. And we'll quite often see patients' postures improve to some extent, not all the time, but to some extent it will improve. Their airway space, we see that because of the postural changes, the airway spaces will improve as well. But that's not the end of it. We typically need some kind of help, whether it's through fascia or body manipulation of some sort through physical therapy or chiropractics to help their posture, because all of these patients come in with some type of forward head posture rotation, and that's a chronic ingrained position. So how would you help with that?
So our approach is because we deal with that connective tissue, and I want you to imagine, right, that onesie from one foot to the other and whoop, right, like over a hoodie, like I'm locked in. So if I'm being pulled down all the way from my calf and my hip and that, right, I'm also going to be pulled forward. It's like if you've ever seen people walk down the street, like, and they're ready for the walker almost, right? They're very bent forward, right? You want to now see someone that now has to literally hunker down in their fascia suit to be able to fit and be vertical. And this is why you'll see them shuffle, because the feet no longer have excursion to roll through the sagittal plane. Okay. So the way we treat it is actually we treat the imbalance in the lateral, the side to side, which is the frame for a bipedal organism, aka a human standing on 2 feet. It's a balance act. We treat the lateral first. Immediately that corrects some of the rotation. After that is balance, we go after the rotation, and then we work them in the backwards direction away from that. So let me give you a really good visual. Pardon me a second. I'm gonna go grab a washcloth. Bet you didn't see that coming. Hold on.
I'm not surprised. She'll do whatever it takes to get the point
You
across.
know what a Bosu ball is?
What is?
Bosu, B-O-S-U,
Yeah,
Bosu
Bosu
ball.
ball. Yeah,
Uh,
love Bosu
Yeah.
ball.
Or
Yep.
for, a lot of TMJ patients also have head forward posture. So,
So
and so is that fascia pulling you down, or is it your traps pulling you down, or what's, forget
absolutely a
that?
fascia pulling you down. It means your fascia suit doesn't fit now. Have you ever heard that people lose height with age?
Yeah.
Our
sure.
It's not
clients
the vertebrae?
incident, it's also the vertebra. Okay. But and again, the vertebrae are in there. Yes. Okay. Incidental finding started quite when I started to treat using the fascia-based approach. People would come to me and I like casually, like, oh, I went for my physical. And by the way, my average client was like the youngest was 75. Okay. Seriously, the area I was treating in. And they're like, I got measured at the doctor's. I'm like an inch taller. I'm 3/4 of an inch taller. I'm like, what? What? So the first one, I was like, right. By the second one, I'm like, by the third, fourth, I'm like, that's interesting. So I want you to imagine even half an inch less compression through all of your joints by
Mm.
fitting into your fascia suits. So here's a great analogy. Okay. So for those who I'm going to try to describe it as best possible, but you know what? If you're listening to the podcast, please go to the YouTube video here and watch this because this is going to help you. So if fascia is cloth, our cloth, right? Our birthday suit. And I'm holding a washcloth. And we can see the length of the washcloth here, right? When it's nicely straight out, there's no kinks or bends in it or anything, okay? When people come to me and you,
Yeah.
this, and right, they've got all these kinks and bends and all this kind of stuff. Can you see how much shorter that is now? Okay. Can you see the length of things when you open things up, right? The tissue is all nice and lengthened out. There's no twists and bends. And all I'm doing right now is I'm taking the same amount of cloth and I'm just twisting it and you're going to see the bends start. Okay. So what we do is we gently open the bend. We help them untwist. And now we increase the range of motion in that backward range. One of the reasons is because we specialize in people who are just hurting often, almost everywhere, that in the past, a lot of that specific population, if I made them go backwards on a Bosu ball or a physio ball or it would be too much. It would increase, right, the discomfort because their bodies were not ready for it. Now, I did do another video on my YouTube video is specifically for thoracic extension. And I mentioned the Bosu ball and I mentioned the physio ball. And if you are not dealing with chronic pain issues, please, for the love of God, use those things. Okay, and you could start to use them, right? Because you should hopefully not encounter issues, right? But that's what it is. So you really have to think it's not just so. If you ever I've seen this was a lot early on in my career. I would see this prescribed to a lot of people. They tell them, right? Someone comes in and they have a massively forward head, right? They're really kyphotic and their head is like whoop in the front of the room. And they give them an exercise to put their back up against the wall and put their head up against the wall. Does that like if for anyone that's not watching, I look like I've just Pez dispensed my neck, like I'm hurting my neck right now to do this. They're not able to do that. You have to give them enough material, right? Open up their fascia, open it up until that upper back can touch the wall and then teach them to bring the head back. And now they've got proper, right, posture alignment. Okay. Does
Yeah.
that make sense? So forward head, I said this in the presentation and I had some really good questions that the head, the skull, and the jaw are slaves to the axial skeleton. They are a balance act. Now, the neat thing is that because it's the top of the building and its center of gravity, when you correct the jaw, you can actually affect the rest of it. Okay. It's not just from the ground up, both work. Okay. And I told you what I found early on, you've got to work on the feet and the head to create the quickest solutions, the feet and the head. Everything else has to adapt in between. So you guys are working this piece at the top.
I love it,
It's just
Dana.
fascinating. It's
Yeah.
just fascinating.
That
Now,
New
I
way of
was telling,
looking at it, right?
that visual of the towel is so perfect and makes complete sense. I'm gonna have to steal that in my office. Not that I'll know what to do necessarily, but I'll know how to guide them.
So I'll give you a tip. What a few of our referring physicians do, because I've tried. I just send them your videos and you can send them this clip, literally just that piece, like do a clip of that and do it. Because
I
when
will.
people, they're like, huh, Okay. Because otherwise we're all talking fascia smash up. What does it mean to me, right?
Listen, guys, I hate to do it. We're running out of time, Dana. No, it's never enough time with you. And we need our listeners to know how to reach out to you and connect with you. Again, we're speaking with Dana Sterling. Her company is Sterling Structural Therapy, and I believe that's also the name of your YouTube channel, correct?
Yes, it is.
Tell our listeners and watchers exactly how to connect with you. I'll be sending you clients for sure because your non-surgical approach and what you do for people is just it's like nothing shy of a miracle. So how do people find you?
And by the way, I highly recommend to anyone thinking about it, go read our Google reviews because it should, I'm slightly passionate about this, but I'm also very biased for obvious reasons. But read it from the people who've gone through it. Okay. If you're interested in seeing if Sterling structural therapy, right, might be the right approach, complementary approach for you for chronic pain conditions or in conjunction with some of the TMD, TMJ type treatment that you're getting, Sterling structural therapy. And honestly, if you even Google Sterling fascia, it will pop up. Our videos will pop up on YouTube, Google, everywhere, that kind of stuff. We've got YouTube videos, which I actually really recommend to go and look at because it'll give you a lot more information.
Fantastic.
And from my website, if at that point you go, you know what, let me give this a shot, because I always tell people, you've got to lose is 45 minutes in the Zoom room. That's it. It's that free consult. Then just click that button on the website, send us your request for the consult. What I will say, if you came from this podcast, say that you found us from this podcast, and because normally I don't do the assessments anymore, I just help them out if they're too busy. But we'll make sure if anyone is coming and booking the consult as a result of listening to this podcast, please just say that you have, write the first initial reach out, and then we'll schedule you directly with me. Okay, for the consult itself.
Thank you.
Okay. Yeah, no, and I love doing it. I still do. I mean, I think I know a high well, Mac, but I'm slightly obsessed with this. So yeah.
You absolutely exude passion and you just breathe knowledge, woman. Thank you so much for being
Guys,
here today with us. And
Yes, thank you, thank you, thank you.
Mac and I
pleasure.
would definitely will ask you to come back because this is just the
Yes,
tip of the iceberg. Dana, thank you for your time and your passion and
A-
what you do for people.
Absolutely. And I can even speak more specifically about forward head next, whatever you want, right? It's pun intended, it's all connected. Okay.
there you go.
Okay.
All right.
We'll
On
have a
Thank you
that
lot
so
more.
note,
much.
bye guys. Have a lovely weekend. It was such a pleasure. Bye
My
bye.
pleasure was ours. Thank you. Bye, Dana. Bye, Mac.